Male breast cancer is 1% of all breast cancers. Is that statement clear?
Yes.
There's one more thing which is 1%. Sarcomas are 1% of all cancers. And there are 100 subtypes of sarcomas. So imagine 1% and then 100 subtypes. So you need immunohistochemistry to find out. Some respond to some therapy, some don't. So we need to be very, very careful about the immunohistochemistry. That's why this FNAC is not done in sarcomas. It's useless. We do a core biopsy because you need the tissue, biomarkers, the grade, and the staging in soft tissue sarcomas is GTNM. Not bad left. G is grade, TNM. And grade you can't make out with FNAC, therefore core biopsy or tissue biopsy is the mandatory. Then the male breast cancer is also related to BRCA genes. BRCA2. Other. BRCA2 would also include colorectal cancers, pancreatic cancers, all other cancers. So you need to take that history carefully. And there is an indication for doing that test. The genetic testing after genetic counseling is done. Because genetic test also cannot be done without counseling. Can you tell me why, Devika? It's a common sense question. Doesn't have any science in it.
So if something unusual comes into play, then the patient is not. I mean, the patient should be aware that there might be things. He might be having procancerous genes that might be made aware of. So that the patient
risk is, I think I get your answer. The risk is that you may unnecessarily alarm him or her and give the kind of anxiety that she or he can do without. Or you may be wrong in your prediction. You may never develop. You see, everybody sitting in this room and standing has got a cancer. You all have cancers. So don't worry about it. But your immunity is such, you suppress the genes that don't let it go haywire. These are called tumor suppressor genes. When they undergo mutation, this goes haywire. That is how we do it. And therefore the penetrance of genes is important, how much they penetrate. It's not always just being positive. There is nobody without cancer in the body. And 80% of women that were subjected to postmortem, after they died a natural death, more than 80 years of age, at DCIS. 80% men, post 80, when they died, they had prostatic cancer. But they didn't die of it. Now you get the catch. So a lot of them are man-made disasters. That's why they are gradually realizing in situ ko chhod do. So lobular carcinoma in situ is out of cancers list. Ductal carcinoma in situ, don't scare the hell out of the patient. They all may not become invasive. So you should be clear. Back to the male breast cancer. Male breast cancer is gynecomastia a risk? It is a risk. But it is usually the unilateral gynecomastia because bilateral would usually be due to a systemic problem like liver disorders. Why in liver disorders you have gynecomastia?
Increase amount of estrogen.
Very good. Because these hormones are metabolized in the liver. So liver is not metabolizing. And we all have estrogen. And we all have androgen. So this fuss about males, females being different species is very easily beaten. There's one tweaking here or tweaking there, you're gone. You're either side. So estrogen, there are androgen receptors that are more reliable in breast cancer than estrogen receptors. We have done study on ARs. Pranjal was the very famous cancer surgeon today. He was my student. His thesis was on androgen receptors in breast cancer, neoadjuvant protocol, etc. So there are mix and match things, right? Back to the male breast cancer. Gynecomastia can be a risk factor, but especially in the setting of Klinefelter syndrome, as you mentioned, which is trisomy. Trisomy means what, Surya?
An extra chromosome.
XXY.
X.
So that trisomy increases the risk. But the risk is more naturally if it is unilateral, because that is more likely to be something wrong locally. Somebody on estrogen therapy, say in some cancers or otherwise, it can happen. Old age, testicular atrophy due to any cause, it can happen. Because same reason. If you don't have more testosterone, you have more estrogen. Androgens, clear? So, most of them are not amenable to breast conservation because there is no breast to conserve. So there very rarely you would need it. Most of them undergo modified radical mastectomy. And you saw this patient had very large nodes. You remember that patient? Male breast cancer. So there is a propensity for developing lymphedema due to axillary dissection. And patient has gone home, was lost to follow-up, sadly, needs radiation and chemotherapy both. All patients with locally advanced breast cancer require radiation. I taught you what is locally advanced breast cancer then. Did I? So what is it?
So locally advanced breast cancer will be in one breast, not through the other breast, in one breast or the axilla of that breast.
Or the supraclavicular lesion.
So what is an LABC?
So, tumor invading the skin or the supraclavicular or the ipsilateral axilla.
Stage D3.
Any T4 with any N, N2 with any T.
And M0. T4 with any N or N2 with any T and M0. And some people take T3, N1, M0 or size more than 5 cm or also locally advanced. See with that. So that is what they mostly are. We need to give radiation to all LABCs. There is no exception to the rule. So here there is no conservation. There is going to be mastectomy and there is going to be radiation. The radiation is given, even in mastectomy in these situations. Okay?